Hospital-acquired condition. A hospital-acquired condition (HAC) is an undesirable situation or condition that affects a patient and that arose during a stay in a hospital or medical facility. It is a designation used by Medicare/Medicaid in the U.S. for determining MS-DRG reimbursement beginning with version 26 October 1, 2008. Not only hospital-acquired infections but also any other situation or condition, such as pressure ulcers, blood type mismatch, or iatrogenic injury, can be an HAC. A patient at a hospital can be infected or otherwise degraded by hospital conditions and/or personnel in ways that are sometimes diagnosed as a complication. The US Medicare system designates some 1,000 plus ICD-9 CM diagnoses out of over 14,000 as of 2009 as possible HAC. On February 8, 2006, the President signed the Deficit Reduction Act (DRA) of 2005. Section 5001 of DRA requires the Secretary to identify conditions that are a high cost or high volume or both, result in the assignment of a case to a DRG that has a higher payment when present as a secondary diagnosis, and C could reasonably have been prevented through the application of evidence-based guidelines. Section 5001 provides that CMS can revise the list of conditions from time to time, as long as it contains at least 2 conditions. On July 31, 2008, in the Inpatient Prospective Payment System IPPS Fiscal Year FY 2009 Final Rule, the Centers for Medicare and Medicaid Services CMS selected 10 categories of conditions for a HAC payment provision. For discharges occurring on or after October 1, 2008, hospitals no longer receive additional payment for cases in which one of the selected conditions was not present on admission. That is, the case would be paid as though the secondary diagnosis were not present. Categories of hospital-acquired condition. The following are the current, as of October 1, 2009 MS-DRG V27, hospital-acquired conditions, conditions selected for implementation. These conditions will have payment implications beginning on October 1, 2008. Object left enduring surgery 998. 4 cc. Air embolism 999. 1 mcc. Blood incompatibility 999. 6 cc. Catheter-associated urinary tract infection 996. 64 cc and one of the following specific infection codes 112. 2. 590. 10. 590. 11. 590. 2. 590. 3. 590. 80. 590. 81. 590. 9. 595. 0. 595. 3. 595. 4. 595. 81. 590. 89. 595. 9. 597. 0. 597. 80. 599. 0. Pressure ulcers 707. 0. 1 and 77. 9 cc 707. 29 mcc. Vascular catheter-associated infection 999. 31 cc. Surgical site infection mediastinitis after coronary artery bypass graft cap surgery 519. 2 mcc and 36. 10. 19. Falls and trauma fractures, dislocations, intracranial injuries, crushing injuries, and burns codes will be considered in FY 2009 IPPS proposed rule. Falls are a leading cause of hospital-acquired injury and frequently prolong or complicate hospital stays. Falls are the most common adverse event reported in hospitals. Almost all of the 1,000 plus diagnoses that are possible HAC are designated falls and trauma. Determination. When a diagnosis is recorded, it is designated either present on admission POA or not. If the diagnosis is POA, it is not demoted. However, if a diagnosis is not POA, it might be demoted. Most HAC diagnoses are demoted if they are not POA. Some that are not so simple are designated above with the tag PROC, diag, or both. In those situations, a diagnosis must also be accompanied by one of a specific set of diagnoses, procedures, or both to be demoted. For instance, if a patient falls out of bed while in a hospital, the consequent broken hip was not present on admission, so the complication of broken hip would be demoted as a falls and trauma HAC. The hospital would not be compensated for treatment of the injury. The intent of this sort of classification is to force hospitals to prevent such problems in the first place.